And so it's important that not only do you understand what are some common policies, but also how to be a helper or a team member when it comes to developing policies, why you would develop a policy, et cetera, et cetera. So let's get right in there and talk about one of the things we need to know. First and foremost, you know, when we talk about the rules and the guidelines, we're looking for risk adjustment at ICD 10 guidelines, okay, or just ICD guidelines. We're not talking about PCS, those codes. We're talking about the diagnosis codes. And with risk adjustment, there could be several things that you're looking for in risk adjustment. It could be just the RX HCCs. It could be HCCs and RX HCCs. You could be doing something special in risk adjustment for end-stage renal disease. They could be having you do a contract where you're going to go out and abstract for commonly missed conditions like status conditions like ostomies, amputations, and et cetera, et cetera. Again, understanding why you're doing what you're doing for a given contract or job will help you to understand the rules. But for the most part, the first thing we know is that we're going to follow the coding guidelines, the guidelines for coding and reporting with ICD. Now, there could be, again, changes and differences within that. So be open to that. Don't debate, don't argue. Nothing wrong with questioning and saying, I'm not sure I understand, and they'll be more than happy to explain it to you. I feel that if you understand why you're doing what you do, the long-term effect, then it helps me as a coder or in a contract to better to code to a higher specificity, and also to be faster, because you know that in the back of your mind. It's almost like you're going to play baseball and the coach says, okay, we need to get as many home runs as possible. And then a little bit later he says, we need to get as many people on base as possible. Okay, so you know you're playing baseball, you know the rules, and for whatever reason he wants you to get a home run, and then another time he's saying, I don't want you to get a home run, I want you to get as many people on base. Okay, so if you understand why you're doing what you're doing, it makes sense. The guidelines that we follow with ICD and risk adjustment is based on Medicare and Medicaid, or CMS guidelines. Now, this also really applies to HHS, and some of you may be HHS coders versus CMS coders. For the most part, that just means that you're doing different age groups, whereas with, you know, CMS, you're doing 65 years and older, or people with end-stage renal disease, unique, you know, scenarios, maybe disabilities and things. But with HHS, you're not. Okay, that's going to be Medicaid, all ages. That means you're going to have prenatal stuff involved, and as well as all age groups. Right. Medicare is national and Medicaid is state level, but private insurance risk adjust as well. So you could be working for a private insurance company and they're wanting to make sure that their providers are following risk adjustment rules, both for HHS and CMS. You might be part of the training involved in that, or an auditing type role. Another resource that's extremely helpful to you is the coding clinic. Now, the American Hospital Association, or the AHA, puts out a document or a magazine for coding clinic, which is the authority, more or less the coding standard authority. Whenever anything's ambiguous, they address it, and then whatever they say through coding clinic, usually Medicare and Medicaid kind of agrees with that. Okay, so you have a group of professionals that when we have gray areas, they say, okay, this is the best way to do the coding in this scenario. So coding clinic is very expensive. So if it's provided by your employer, hey, that's a great perk. You know, that's wonderful to have access to that. But don't feel bad if you don't have coding clinic at your fingertips individually, meaning you have access to it, because you can still go out and do research and find out what coding clinic has said about something, because there'll be articles that comment. It's referenced all the time, and it again is an authority that you can trust. Where else can you find rules like your code book and coding clinic? For the most part, you're going to find them from your employer. What is your employer state? What's the policy where you're working? Maybe it is a Medicare, just a Medicare policy. Now, if it's not addressed in coding clinic, but if it's a Medicare policy, it's probably addressed in coding clinic. And you want to really be careful with your sources, and we'll talk about that in addition. So when you go to set out policies, what's the first thing you need to know? You need to know, is there actually a policy already set in place for that? Right? And CMS is a great site. Whatever Medicaid does, or excuse me, Medicare, since it's the largest payer in the United States, then they kind of lead the way and set the bar. So whatever CMS states, usually everybody is compliant to that. Not always, there's always exceptions to the rule, but if CMS states something, cms.gov, you can go there, then that's a tried and true rule or policy. Also, again, we already talked about the code book and coding clinic, but the example that they're giving here is what to report when the type of diabetes is not specified in the documentation. That's in your coding manual. That guideline, you know, is right there. You default to type 2 diabetes. Why? Because like 95 or 98% of all diabetics are type 2 diabetic. So therefore, it makes sense that the guidelines tell you if you don't have that information, you default to type 2. That also is true for when you're coding for sequelae or late effects or hemiplegia of a CVA. We want to know, is the patient right hand or left hand dominant? And if you don't know if the documentation's not there, then what do? The guidelines state you default to type 2, or you default to right-handed dominance. And why? Because statistics show us that most people are right-handed. Okay, can you be wrong? Yes. Are you going to get dinged for that? No, you're not, because you did what the guidelines directed you to do. Let's look at the second scenario. What are you going to report when the patient is diagnosed with an acryloplosamania? I tortured that, but you see it there on the screen. After examining the patient's blood work and family history. So what are you supposed to do? Well, let's look and see what they give us. On that first one, we know the guidelines of type 2, but let's look at the second one. Now, I wanted this all on one slide, so I made it a little bit smaller. I'm sorry that it's smaller. I don't like to do that, but I didn't want to chop it up and put it on more than one slide. So according to the National Organization of Rare Diseases, because that's what this is, thus another reason why I can't pronounce it properly. I did practice it, but it doesn't roll off the tongue. It is an abnormal accumulation of iron in the brain and a buildup of iron in organs, and that it will affect the neurological system. It also causes cognitive impairments and movement disorders. We also need to know that sometimes it's called hereditary ceruloplasmin deficiency. Okay, so again, now we know more about the disease itself, and then it can help us make a decision on how to code it. And then they're even telling you how to search it. This is what you would do. You go into deficiency, you look up that ceruloplasmin, okay, and it's going to say, hey, go to E83.01. But when you go there, it says this is Wilson's disease and a copper metaplasm deficiency, metabolism deficiency. Whew, tongue twister. Okay, but then if you look in that same area, you see E89.19, other disorders of iron metabolism. So because we looked and saw what Nord said, then we know that really the proper code to use would be E89.19 because we did more research and we see that it is a iron buildup, not a copper metabolism deficiency, right? Always keep track of the research that you do. If there is a debate about, getting to the highest specificity or what code to use, you want to be able to back up what you're saying. Now, how often are you going to run into this rare disease? Probably not very often. You may never see it again in your lifetime. And then again, depending on where you work, if you're doing specialty work, you could come across this, and a policy would be written for your workplace, that this is a better code to track, because we're coding for statistical purposes, not just to get paid. And you've always got to keep that in the back of your mind. The next thing you need to ask yourself, do we need a policy? Why would we even need a policy surrounding this? Well, there's two main reasons. Time and money. Money predominantly is like the squeaky wheel. Everybody is needing more money, and so we want to avoid fraud and abuse, but we're not even talking about that. We want to set a standard, and money is what is the squeaky wheel. But also time. We don't want to debate this. We don't want to have to think about it every time. We just want to go to answer. Not only does that save us time, but in the long run, that saves us money in the trenches coders, right? To set a policy in place. Hey, we keep running into this. So to save time and to answer your questions, this is our policy. Looking at it from another viewpoint, you can say, hey, we do not want to get audited on this. We don't want to get dinged. And we know that if the government comes in and audits us, they are looking for mistakes. Those type of auditors get paid to find mistakes. And with that being said, we're going to establish this policy so that we can be consistent, and then they don't look at us with that eagle eye looking for more mistakes, because we're showing that we have policies in place. And if they want to correct us and want us to change that policy, we can do it. But we're showing good faith effort in that when we have anything that's ambiguous, we have a policy in place so that we're consistent. So we're not doing something wrong on purpose to cheat or to do fraud and abuse. Instead, we're trying to be compliant. Disruption of production, again, an example of that. When should something be a family history code that needs to be abstracted? Okay, maybe it's not pertinent that it's a family history code, and so we're not going to abstract that because it's not pertinent for what we're abstracting for, right? So we set a policy and says, hey, save time, just don't look at that. It's not going to be pertinent for this scenario or this group of charts that you're auditing for. Another one would be quality score of coders with risk adjustment. Time is money. That's true. You want to be fast, but They want quality over quantity. You know, we want to get to the highest specificity. We're talking about, in the long run, a lot of money that's being set aside. That's often why new coders aren't put in inpatient coding roles as quickly as outpatient, because there's more money involved. If a mistake is made, you're losing tens of thousands of dollars, not $1,000. Okay, and with risk adjustment, you're not just losing thousands and $10,000. You're losing hundreds of thousands of dollars, so or more. So again, quality scores are tracked. If you have a specific policy and guideline, that's going to give you a baseline for quality. Everybody's on the same page and doing the same thing. You don't have these people coding this and these people coding that. No, we're all on the same page. And so our quality will go up, our quality score. The example they're given here is a history of cancer code. Okay, if a patient's documented as still undergoing chemotherapy, but the documentation is showing that it's a history of cancer, what's the policy? You know, what do we do with that? Some people are going to code it one way and some people are going to code it another. But if you have a policy in place, everybody does it the same way, and that quality score goes up because you're all literally on the same page. What about financial risk and audits? Already alluded to that. So if you have a physician that does a reverse stages a pressure ulcer in documentation, what's that going to do? Well, was it coded and abstracted at the highest stage? Again, pressure ulcers put out a lot of money for risk adjustment because of the care and that's involved in the time that it takes to heal. So if you have a stage 1 pressure ulcer and then they go back and say, oh no, this was a stage 4. Wow, that's a lot of difference, and this guy's going to heal up a lot faster than this guy. So a financial audit can get a big hit if that type of error is made. Again, what's necessary? Compliance with epidemiology standards. So, we know how to code HIV positive and AIDS. We understand that it's different. We understand that it's 2 separate codes, B20 versus Z21. Not only is this a critical thing to get correct for our patient and statistics, but for the amount of money that's being set aside for that patient, right? So a Z21 patient is going to need different care than a B20. But even if they got paid the same in risk adjustment, we do not want to make a Z21 patient a B20 patient, right? That will mess up statistics. And we also need to be very knowledgeable about what diseases in the disease process makes an HIV asymptomatic patient symptomatic and turns them into a B20. There's like 15 or 20 diagnoses that it's bam, it's automatic that you see that documented and you go from a Z21 to a B20. Knowing that and having a policy in place and having that information available to the coders so they can reference that very quickly is going to save you time and save you money in the long run. And you're always going to code to the highest that you're able to abstract. So let's say, okay, we decided that we understand the need for policies. So who should be on the team to develop these policies? The first person that you're going to need is someone that does QA work, quality assurance. And again, a lot of times this is the clinician, and they understand the disease process inside and out. They know the procedures that are done for diagnostic purposes. They know the treatments, the medications, and you want to make sure that that your coders understand everything that's involved in the disease process for quality assurance. So that's a number one person that you can have on there. The next person is you need to have a coder, because your quality assurance person isn't necessarily going to know much at all about coding. Clinicians are often, and providers are called to be a part of the coding, and sometimes abstract codes or select codes, but they're not trained in the guidelines. And often you find that they're very frustrated with it. It doesn't come easily to them. It doesn't make sense. It isn't what they want to do. When I was doing home health, that's the first time I ever met people that hated coding, and I couldn't understand, because to me it was so much fun. It was so much better than being a clinician, and you still got to be involved and do the aspects that the clinicians do, but you never got your hands dirty, and you didn't have to smell the smells, and you didn't have to be on your feet all the time, and you know, so again, the pros and cons, I was thinking, that how can you beat being a coder? But again, the coder speaks a different language. Even though it's similar, it is still a different language. Our job is to translate and be that liaison for the documentation that we're given, and then translate that for statistical purposes, as well as translating that for the payers, so that our providers can get reimbursed for the work that they're doing at the highest level. You know, you don't want them to be underpaid for the work they're doing, and you don't want them to be overpaid for the work that we're doing. We want it to be fair. So absolutely, coding representatives need to be involved. Next, consider your training representative. You can have the best QA person, you can have the best coder, but if they are not a skilled trainer, you're not going anywhere, right? And it does take a special skill set to train. You know, you can't just tell somebody something. You can't just say, okay, and this is the way you code B20, and this is the way you code AIDS, and this is the way you code HIV. This is the way you code pressure ulcers. No, you can't do that. You have to be able to tell if they're getting it. You have to be able to give rationales. You need to be able to give scenarios that help them retain the information. You need to be able to sometimes physically see the light bulb coming on. I like to tell people how I met Laureen, the founder of CCO, in that I was teaching in a brick and mortar college setting, and my students weren't getting E&M. They just weren't getting it. It made sense to me, and the way I was explaining it, though, it wasn't clicking for them. They were getting frustrated. I was getting frustrated, and I was almost to the point where just saying, just do this because I say so, right? You know, just do it. But that doesn't work that doesn't work. And so I came across her videos and the way she was teaching E&M, and I thought, oh, wow, that's really unique. That makes sense to me. Maybe they'll get that. And sure enough, when I had them look at those videos, you could see the light bulbs going on. And you're like, I get it. They were thrilled because it made sense to them. She had developed a technique that she ended up using to teach herself E&M with having no background in that at all, versus me having a background in this area, trying to force feed what I knew to people that had no background in it. Okay, so I wasn't doing a good job. They were getting other things, but they weren't getting that. And to be a really good trainer, you have to be able to recognize that. If it isn't working, switch techniques. Do something a little bit different. And again, it's a skill set. Plus, we have to remember we have all different types of learners. You may have somebody that's a real audio type learner. If once they hear it and it's explained, it's fine. It's in there. And then what if you have a person that's a visual learner, which is pretty common, but what if you have somebody that's really a tactile learner, right? They need to touch the manual. They can't just look at it on a screen. They've got to be able to write it out and touch the paper and stuff. So again, a trainer understands that. So don't overlook having that on your team. Management. Why would you need to have management? Well, because they understand the business side of why we do what we do. Now, as coders, especially in risk adjustment, if you're what I call that in the trenches, you work for an MAO plan, and all you're doing is abstracting documentation. You know, it's all you do is look at documentation and abstract those codes. You don't care what somebody's risk score is. You don't care, except for as it's pertinent to the code, that it's a male or a female patient, or whether they live in Boston or they live in Houston or they live in, Podunk, USA. You don't care, because that doesn't make a difference for the most part in the disease process, and you're abstracting the information. But in management and the management aspect, the business side of risk adjustment, absolutely it's pertinent, and they need to have a say in why a coding policy would be done a certain in a certain scenario, because it affects the funding that's coming in. They can see the long term, and so they want to have that voice in not necessarily in the trenches, but when you come into a scenario that says, hey, should I do this or this code? Well, which one pays out more? Well, an in the trenches person doesn't think about that, right? If it's an either or, then you just need to tell me which one. Write the policy and tell me which one. But management will say, when you have these scenarios in place, this pays out more for that patient versus this. Now, I'm not saying that we base our decisions on which pays out more. We base our decision is if this is on equal footing and I can pick either one, and back up either choice, this code pays out more. So that's the one that management would say to pick. It's no brainer then, or if we pick this one and then later they come back and tell us that no, that's not the right one, we're going to have to pay a whole lot more money back with a mistake than if we pick this one. So long term, outlook, let's go ahead and take the one that takes less so that they'll end up paying us versus us paying them. So management makes choices like that. And then the quality assurance person, it doesn't affect them. The coding representative says, in my way of thinking, both are applicable. This is a really gray area. So you just tell me which one to go forward to. Also, another person to consider is a billing specialist, someone that is part of the payer group. Have them give you insight as setting up a policy. And that falls into under management too. The same reason why you would want management there, the payer can look at that. They can resource their statistics, and they can tell you what their payer, what that insurance company agrees with, and what they say their standards is. So you may change your policy to meet what Blue Cross Blue Shield says, because Blue Cross Blue Shield is the biggest payer in your area, right? So it makes sense. Go with what Blue Cross Blue Shield says. And if UHC has a different policy, then again, you can back it up and say, we were following the guidelines we were given with Blue Cross Blue Shield. This is why. And then you can get a representative from UHC that says, yes, we accept that, or no, in these scenarios, we do not accept that. We want you to do it in another way. And therefore, it goes into the policy. Look at who the payer is. If the payer's, Blue Cross Blue Shield, this is the policy that you'll follow. But if it's UHC, this is the policy you're going to follow in that particular scenario. So the policy's written. All of those people are going to work as a team. And I think that it's pertinent to know that all of these areas are ones that should have a voice. Are they going to be the one that independently makes the choice for you? No, it's a team effort, and you're pretty safe as long as you have a policy in place. Like I said before, when the auditors that are paid to find mistakes come in and they say, why are you coding it this way? This is wrong. Then you walk out with your compliance notebook or your policy notebook and you say, we have got the policy team consisting of these people, these experts, or you don't even have to tell them, came up with a policy. This is why we do it this way. We made the best choice that we could with the information we were given because it's ambiguous. And so that's why we do it, and we're consistent, and we always do it this way. Then they know you're not trying to fraud or abuse the system. Okay, and then they can come back and say, no, we want you to change your policy. We don't accept that. And then you do what they say, you rewrite the policy, and then moving forward, you have a new standard. And then when they come back, they see that you are following the new policy, and that's acceptable, and you don't get dinged for that. Okay, you like how I say dinged? I always think of a pinball machine, ding, 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 because you don't want dings. You don't want that pinball number to go up. That's a bad thing in coding or being audited. You will always be audited. It's a way of life as a coder. It doesn't matter if you're in risk adjustment or not, because the guidelines change, the policies change, the disease process sometimes changes as the statistics that we provide, the data we provide for statistical purposes, opens up the education window, and they can see, hey, this is why we know this medication works for this particular disease because of the statistics from the coding that was done. So therefore, protocol for this disease now changes, right? And it all trickles down into the codes. Well, another thing besides auditing that you will always be doing as a risk adjustment coder is research. If you like research, then you're good. I always kind of laugh just because of myself when people say that they like coding, or they think they'll like coding because they like putting puzzles together, because honestly, I don't like putting puzzles together. I'm an instant gratification type person, and a puzzle is slow. So, yes, if you enjoy putting puzzles together, yeah, that's true. That is part of what you do. However, I don't like putting puzzles together, but I do love research because I love increasing my knowledge base. I love to go to conferences. I love to go to chapter meetings and listen to different speakers, and because I like the disease process. So, I like to tell people, like last year, I really tried to increase my knowledge in interventional radiology because, and interventional medicine, because I wasn't very good at it, and it's intimidating. And I did. I learned a lot. I gravitated and picked those particular lectures, and I went and researched and found resources. So for the new year, I've picked a couple other things, and I'll be working on those. I love researching, and I love learning more. I love that aha moment when you say, I didn't know that, or where you walk in and you say, tell me something I don't know. And there's a lot I don't know, but just when you think that you're Mr. Smarty Pants and you think, oh, I didn't know that. That happened to me at one of the regional conferences last year, and I mean, this was a great speaker and just took me by storm. And there were some things that I didn't know that you could do to the heart I thought, how come I didn't know that? That seems so simple. And so I would ask around, say, did you know they do this? And some people say, oh, I didn't know they could do that. And so again, that to me is extremely thrilling, and one of the reasons I love what we do. We read documentation and increase our knowledge base, and so we learn the procedures, the lab tests, the diagnostic procedures and stuff. We see outcomes of the disease process that most people don't have access to as risk adjustment coders. Anyway, research. So we can't just go out and find what we're looking for. It's pretty funny that when WebMD came out, that was so cool, right? Because it gave you as the patient or the person that had something wrong with him the ability to jump out on the internet, and in a few strokes you could figure out if you were dying or not, right? So I got this abdominal pain, you know, and then it kind of became problematic, because it's good for you as a patient to become knowledgeable. You want to know things surrounding what's going on, but just because you read it, you don't understand necessarily as a layperson how medicine works, all right? And we pick and choose what we read, right? And we also have a tendency, it's human nature, to always think it's much worse than it actually is. I know we used to call that a hypochondriism, right? But it's not even that. We just always think the worst because we get worried. And so it's kind of an ongoing joke in medical societies now that, you know, if you go and look up anything on WebMD, it eventually will lead to brain cancer. You're dying of brain cancer because you can keep pressing these links and saying, oh, yes, I have that symptom. Well, then it opens up another field and says, oh, sure enough, I have that symptom. Oh, wait, I have that. And next thing you know, you are dying of brain cancer. And it's because, you know, you have a pain in your pinky. So, you know, and it's funny. So take where you get your research from seriously. And as professionals, you know, as risk adjustment specialists especially, but as a coder, there's some things that you need to look at to determine if this is reliable sources. You need to know who the author is. Now, of course, WebMD is great. You know, that's great. However, if you don't understand the disease process, then you can get off on a tangent, right? We're not going to go to Wikipedia for anything, not anything. It's not a reliable resource. I know some of you have seen on our webinars and stuff in the past that Chandra used to say that she made herself the Queen of England and it stayed up for 2 weeks in Wikipedia. You know, so again, you have to understand how Wikipedia works. Now, Wikipedia is good for information if you want to know what actor played in what movie, but that's not a reliable source in the medical field. One thing you can do if you don't have a launching point, you can go to Wikipedia, look at their resources that are cited. So if you want to understand more about melanoma, you could go out and look at it and then say, oh yeah, the American Cancer Society was linked here. So I'm going to go look at the American Cancer Society and see what they say about melanoma. That's different, right? You're actually going to a reliable source. Also, you need to determine what's the motive for the article. You know, is it a blog? Because blogs are opinions, and they will cite resources, but sometimes the resources are also opinions. Not saying that you can't use a blog as a stepping stone to get more information, but what was the purpose of the author putting this information out there? Couple things to consider. If I want to pull a case for a case study for my students to look at, and we abstract and we talk about the disease process, and say I want it on osteoporosis, and I see that there's a particular procedure that is relatively new, and I go to an abstract where this particular provider is telling, the purpose for this case study is to show other orthopedists that this particular procedure works really well with patients who have hip fractures due to osteoporosis. Okay, that's the objective of the author. They have a reason why this is being submitted. So the things that they say about osteoporosis and pathological fractures is based on them telling you about this study that they're doing in this procedure, versus going to another site that is orthopedists, and they're talking about the disease process itself in osteoporosis, not centered strictly around fractures. And then maybe you find another source that's an endocrinologist, and they're talking about the hormone levels in women and how after you go through menopause, your body just more or less stops producing this estrogen, and therefore osteoporosis is the result. So there's 3 different reasons and objectives, 3 different authors. And if you are wanting to look at something regarding hip fractures, then you're not necessarily going to use the site from the endocrinologist that's talking about hormones. And you think, okay, well, good, the orthopedist is one, but yeah, he's not talking anything about pathological fractures. He's talking about osteoporosis, and yes, you're more likely to get fractures, but the site that has the information that specifically is pushing a new technique for the healing process of hip fractures, it's all about hip fractures. So again, that's great, right? That gives you an understanding of the author. You know, they're not trying to sell you something necessarily, you know, because then you got to take it with a grain of salt. And they do that in the medical field as well. You need to know when the information was written. What if the information was written and it was done, 10 years ago? Well, in medicine, that's a lifetime ago, right? That's a really long time. Now, for the most part, things don't change, but every year new innovations are being made. And what if you do a Google search and you see this article was written in 2008, and then you see another article that was written on the same subject and it was 2017? Well, you're going to go look at the 2017 article because it's been updated. You know, it could be a different author, but it's going to be the most relevant. So think of it as a coder. That would be like, I'm going to go and look at that ICD manual that I have from 2009 sitting on my shelf versus having the year that you're in right now. Major guidelines changed. You know, causal relationships weren't the same in 2009 as they are now. The way we code diabetes and comorbidities is nothing like it was back then. Now we can code level of blindness. They want us to be able to code that, whereas we didn't do that in 2009. And so, and in 2009, we were using ICD-9. Whereas now we use ICD-10. So it's not applicable. When the content was written is very important. The integrity of the site, of course, is we've already kind of mentioned that. Reputable websites. Again, you're not going to document anything off of WebMD. But as a risk adjustment coder, one of the places that I like to go to look at medications and why medications are used, or if it's a common medication used for a specific diagnosis, I like to go to drugs.com. And then one time, to me, I think it's very thorough. But then I had another person that was an auditor for where I worked doing risk adjustment. They said, we don't like drugs.com because, and I can't remember now even why the reason was, and they said, we prefer that you use, and it was another place that, again, it was, to me, it wasn't as user-friendly, but I used it because that's what they requested. Again, sites that you're comfortable with, make sure that follows this criteria. Risk adjustment coders notwithstanding, as a coder, you need to be able to back up and explain why you code something a specific way. If you go tell the provider, hey, I have to code to the highest specificity, so I need to know XYZ. Now, you're not querying the provider, you're just letting them know. There's a difference in that. And they say, well, why? Why do I need to document that information going forward? And then you can tell them, well, the guideline is here. This is the information, the guidelines that I have to follow. And so I have to be able to answer all of these questions to be able to get to the highest specificity so that you can be reimbursed for, you know, the work that you're doing. And it's like, oh, okay. Or the, you know, not just the guidelines, maybe Coding Clinic explains a scenario and say, okay, it's kind of black and white, you know, as far as the guidelines are concerned, but Coding Clinic came out with this statement. So therefore, going forward, when you document, you may, you know, it would be helpful for me to determine the highest level if, and if it's pertinent, if this, you know, was documented. So you need to be able to educate and inform the clinicians and the providers why you need what you need. Consider, say, you are, I like to think of it this way. Say you're teaching somebody Spanish. Well, the words you use in Spanish and the words you use in English sound similar, but sometimes will mean something completely different. So you're just educating them and saying, okay, you know, clinically, you have guidelines and protocol for documenting sepsis, but the guidelines that I follow for coding sepsis, I need these things documented. So again, they're not always the same thing. We don't speak the same language. That's why I'm a coder. I'm that liaison in between. Very good. What's the difference between fact and inference? Well, a fact is a fact, right? It's undisputed. So therefore, you can say, these are my guidelines for coding sepsis. This is what I've got to follow. And then he said, the provider holds this out and she puts the documents and said, these are my clinical guidelines for this facility for documenting sepsis. You know, it's like, okay, now we need to make those meet. We need to make sure that, you know, you're following your clinical protocol and that information is there, and that you understand my protocol as a coder and the guidelines that I'm using, so that we have all of the documentation we need going forward. Right. An example they're using is the IDDM. That is universal, okay, to determine the type of diabetes mellitus that a person has. But the coding clinics will tell you, you know, insulin-dependent diabetes mellitus isn't necessarily the best way to state that, because a type 2 diabetic can be insulin dependent and so can a type 1. Type 1's a given. We know a type 1's insulin dependent. But but if a person is looking, say, well, this is a type 2, you know, and they're insulin dependent, but they're not thinking about how the verbiage of IDDM stands. So if you see IDDM, it's going to be a type 1 diabetic for the most part because of the documentation, but because it's fact. Now, inference is the person's, what they have an opinion on. So they could be looking from a different standpoint. Let's go back to the documentation for sepsis. So you have an ICU doc that is documenting severe sepsis via the protocol and the documentation that he has to have for the protocol and treatment of that patient. And yet that doesn't always translate in what we need, the information as a coder. to be able to, it doesn't link up always. And so it's not that it's an opinion, it's two different protocols. So then you may have him say, well, my opinion is, okay, well, we can only code what you document, but opinion is inference. And they may take facts and draw lines, but they may do it like this, where you need, in risk adjustment, you need a straight line. Research online, again, just kind of reiterating current year. You definitely want to look at the current year, as close to the current year. We know in coding what 1 year changes in the manual to the next, not just in ICD, but all of our manuals. When you do articles, again, search the string, right? Narrow it down to specific sources like NORD, who we already talked about, CMS.gov, their leaders. Keywords, narrow your search down. And you even, we talk about this a lot at CCO, and we've got it in our club, and we've also talked about it in our YouTube channel, Medical Coding Cert, and it will teach you how to do research. If you want to look at NORD specifically, you can go to their website, and there's a way you can tell it, the search engine, or when you put in the URL, to only search NORD, right? And it has to do with colons and spaces, and again, I can't show you that because of the slide deck being up, but take some time and look at that. That's one thing Laureen has shared with a lot of people through the years, and it makes a big difference. That means you're not going to get all of these opinion sites. It's only going to search NORD, no other place. If you want to only look at what CMS.gov states about CKD, you can look at only CMS. Do not use any opinions online. They may look like they're from a reputable source, but unless you can prove they're who they say they are and that they're reputable, then again, you might be fooled. You'd be surprised how many people out there that say they're subject matter experts, that looks like they're subject matter experts, but they have lied. The facts of their background are not true. If you ever want to go and see some examples of that that's not in the medical field, if you've ever heard of stolen valor, where people imitate having been in the war and the military, they tend to really like to call themselves Navy SEALs. Oh yeah, I was a Navy SEAL. And they'll have uniforms, they'll look legit. Now, a real military person or a veteran identifies very quickly what looks out of place. And if they always say, well, I can't, that the reason you can't find that information is because it's top secret, it's classified. No, that's not gonna, that doesn't happen. So again, this hurts people. And the same way with looking at online, you're never going to fail if you look at CMS.gov, right? But if you're looking at a site and they say they got it from CMS.gov because they cited it, and then you can't find it on CMS.gov, you need to go out to CMS.gov and find out for sure. Extremely important. A few other things: make sure that its entry is fair and balanced. Okay, and meaning if you're looking at something and you're thinking, is this a reputable source? Well, if they're just one-sided, this is the way it is and there is no exception, then take that with a grain of salt. Is it a credible source? Okay, so if they say, I got this from CMS.gov, that's a credible source, but you should cite everything. So if they give you a link to go look at it at CMS.gov and you go find it, that's credible. That's a credible source. But if you use that link and it's broken, and then you go to CMS.gov and you do a search and you can't find it, That's not a good thing. No, mistakes are made and links are broken and stuff, but again, we know how to research as coders. Is the person who wrote this an individual, or are they associated to an organization? So whatever I say as a representative of CCO, I have the backing of CCO. If I do something wrong, if I say something wrong, then again, I'm representing CCO, and they're going to make sure I say it correctly. Whereas, like, if you're looking at a HEMA and someone's writing an article for a HEMA, they're going to fact check that before they set it out. The same thing with the AAPC, AMBA, all the different organizations out there. If it's part of an organization, it gives you a little more credibility. Is the source pertinent to risk adjustment and diagnostic coding? Now, if it has all to do with PCS or CPT, and that's the way they're coming at it from that angle, then it might not be pertinent as diagnostic specialists, as risk adjustment from that standpoint. So again, you've got to look at the overall picture when you're doing your research. This is a great graphic. So looking at the source and the age of the data. So if we look at before ICD-10 was implemented, that's pretty much out the wall. We're not going to use anything as a resource that was pre-ICD-10 when it has to do with risk adjustment. There are a few things out there, but it's, the ICD overall doesn't change a whole lot, but absolutely the code set completely changed from 9 to 10. Did the disease process change? No, but there's been updates since then. So I really wouldn't reference anything or research things pre-ICD-10. Then after ICD-10, again, limited value. Is it good from an authoritative place like CMS? Federal sources, even they will have information that's out of date. Okay, CMS and RA specific places like Coding Clinic, absolutely, they're authoritative. In less than 12 months. Okay, if you're going out there and you're looking at just websites and stuff, again, pretty limited. You got to take that with a grain of salt. Specialty, yeah, that's better. That's going to hold value. But even your federal stuff is not necessarily going to be up to date. CMS and Coding Clinic and RA specific sites, yeah, that's the best place to go. Now you've got everything ready to go and you're ready to write your policies. So what do we need to do? Well, we need to make sure all of the information that we gathered up has proper citation, okay, so that anybody can go back and reference it. We need to make sure, since it's an official policy, we're not going to make 12 pages. We're going to make it short and sweet, and so that everybody understands. If you go in and you start frilling and foo-fooing it up, then you're doing yourself a disservice, and for the policy, this wastes time too, right? We need to communicate everybody that would be involved a new policy. So the coders need to know, the clinicians need to know, the providers need to know. If you have a billing, the billing department needs to be aware of it. Everybody needs to know that a new policy's been in place. And if you have a compliance person or a compliance office, they probably do a lot of on-the-job training. Maybe memos are sent out and you have to be able to sign off that you read and understand the memo. of the new policy. Every year you go over policies and procedures. This may be something that, you know, is used. One of the places that I worked, every Monday we had a meeting before we started, just to kind of, or what was Wednesdays. So it was in the middle of the week. Anything that needed to be addressed that had come up so far that week, anything that we were working on from previous weeks, do we need to change the way we were doing something? And it even got to, you know, well, is Cindy going to be out of the office? Who's going to take over? Blah, 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 blah. You know, everything was done and we did it in 15 minutes because we were so good at it. Who's going to maintain the record? And who is going to take care of the policies going forward when this particular one becomes obsolete and a new one's written? You know, who's in charge of that? It's usually your compliance person. Next, you have to ask yourself, what are some coding issues you want to see addressed in your coding policy? These are all fabulous. So probably one of the biggest ones that happens with risk adjustment is, what do we do with tamoxifen in a history of breast cancer? You know, tamoxifen is a medication that's given to a breast cancer patient after they've finished their regular treatment. They may have had a mastectomy or not, but they're no longer taking chemo, but they will put you on tamoxifen for 5 years, and because they found that if you do that, you're less likely to have a recurrence of breast cancer. Now, is this active treatment? Some would say yes, that's active treatment for the breast cancers. Other people would say no, the patient doesn't have breast cancer anymore because they've had a mastectomy and they've had, they're not getting chemo anymore, and this is just preventative medicine. So it's, you know, so they are a true history of cancer, and then others will say no, they're actively, you know, so really it's kind of ambiguous. There's a lot of pretty heated discussions out there on which would be the right way to go. It's definitely gray. So until we have a guideline that tells us what to do, you will include, what's our policy? If we have a patient that is no longer getting the regular treatment for breast cancer, the only treatment they're getting is tamoxifen, how are we going to code it? Are we allowed to code it as a history of cancer or not? So once you tell us what we're going to do, that's what we'll do going forward. Will another MAO do it a different way? Absolutely, they could. Will a different facility do it another way? Absolutely. And but it doesn't matter, because you follow the policies that are written in your where you are working or contracted out. Another area is diabetes 1.5, which is extremely interesting because it is a type of diabetes that starts out as type 2 diabetes, and then within the 15 years will convert to type 1 diabetes. And, you know, type 1 and type 2 is very different diabetes. Type 1 is when you understand the disease process, you're born this way. And, you know, you can't go from being a type 2 to a type 1. It's just not, you know, it's not heard of. However, there is this rare type, which isn't as rare now that they're identifying it. And they've been talking about this since the 80s, and they classify it as type 1.5. So if you have documentation, what's the criteria? How do we code this going forward? History of, for obvious recurrent conditions, what's our policies? What about primary and secondary cancers when it's ambiguous and you're not sure which is the primary and which is the secondary? Again, for the most part, we have the guidelines that tell us, but still there is some gray area in there. One of the things, just as a coder in general, that makes us want to bang our head against the wall is when we know it's copy and pasted, right? So you see that medication list and you notice as you've gone through the last 6 encounters for that patient, they've been on over a 6-month period of time, and they've been on a type of penicillin for an upper respiratory infection. You know, that's just, it's been copy and pasted. It's so blatantly obvious that you know, the patient doesn't still have that. Or you have a patient that has had a BKA and has good bilateral pulses. No, that's obviously a copy and paste. So again, what's the criteria? What can we do in those situations? There is some equivocating language. Examples of that is I believe, or it is likely due to, or it's consistent with. If it says it's consistent with, does that mean he's saying yes? Or does that mean he's saying, yeah, it's likely? So what do we do in those scenarios? First of all, you want your providers to stay away from that. Or we need clarification. And as a risk adjustment coder in the trenches out there for an MAO plan, you can't ask and query. So, have a policy set in place. Proper coding for acronyms and documentation. Now, we can go in and look at all proper acronyms and abbreviations, but still you'll find some that are out there. High blood pressure, I've seen it used as an arrow, especially in handwritten. And the MAO that I worked for absolutely said no. A symbol next to BP is not acceptable. Now, a plus symbol and hypertension means it's positive for hypertension and negative for hypertension. Okay, that was acceptable. But an up arrow with a BP does not mean elevated blood pressure from a medical standpoint, and it doesn't mean hypertension. Okay, so again, have that set in place. Ultimately, what are we trying to do? It's very simple. We want order out of chaos. And if we don't want to have those ambiguous areas slowing us down and not getting to the higher specificity, what's going to prevent that from happening is having good coding policies in place. We're going to get better results. Everybody's literally going to be coding the same on the same page. We're not going to have as many problems with auditing because we're consistent. Productivity is going to go up because we're not always asking, well, why are you doing this situation? Or I need to go out and do some research and see if this is what they're meaning. Or I'm going to have to go back and look at that record again. Higher quality scores, which that's quality over quantity is what we want. Job satisfaction amongst coders. We don't have to bang our head against the wall and say, all right, this is copy and paste. If I can prove this is copy and paste, does that mean that I'm not that you can just tell me that I can't use that med list as a line because I can prove that it's copy and paste? It makes it easier for us as the coder. And prospective employees. If I work for a particular MAO and I know we've got a really fabulous rules, regulation, policies, and compliance in place, and I know that we're constantly being updated when new scenarios are brought to our attention, I'm going to go tell my friends and I'm going to say, hey, this is a great place to work because, I don't have to overthink anything. It's right there. I either do or I don't. So again, what coding policies will help you with job attractiveness, and that's it. Make it just as streamlined as possible. That's when you really get to enjoy what you do. Being a risk adjustment coder is a lot of fun. You get to read about everything that's out there. You get to read documentation for patients all over the United States. You get to read all different age groups. You get to see things that you've never heard of and treatments. You get to see people beating cancer. It's really, really cool. And it can be very uplifting, but it can be sad too, because some people succumb. But when you get these really great scenarios where you see a person's been hit, beat down, and yet you see the improvement, that's a feel-good day and a feel-good chart. And so that's exciting. You get to learn a little of these personalities of these people that you don't know, but yet you're rooting for them to get better. And your knowledge really, really grows, unlike with any other type of coding, because it's niche, and this one is so full. And so again, it's attractive to do this, but sometimes you get out there and you're working for people and you're like, oh man, this is so frustrating. You know, you're not making it fun anymore. And if you the need is really out there for risk adjustment coders, and having a good policy and procedures compliance area set in front of you, you'll be much happier. So that's it. This has been so much fun. There's don't forget, you can go out and give in the CCO club some research that you found. Maybe there's some compliance policies they use at work that you think are fabulous, you want to share with others. You can do that in the club. Or maybe there's some gray areas and you want to know how other companies handle that particular scenario. Share them, ask questions, and if you're a student, don't forget you can always go out to your SSH and ask questions in there, but you'll have a lot of fun in the CCO club. That's it, guys. Thanks a lot.